Welcome to the AAST Virtual Grand Rounds. I'm Ronnie Stewart, and it's my pleasure to have two terrific speakers today, Dr. Thea James and Dr. Tracey Dechert. Beginning in 2021, the AAST will no longer offer CME for live Grand Rounds, but CME will be available from the archive version of Grand Rounds for those who watch today's Grand Rounds. You'll receive an email once the archive version is available on the AAST website to prompt you to log in and claim CME. It's my pleasure to introduce Dr. James and Dr. Dechert. I'll start with Dr. James. Dr. Thea James obtained her MD degree from Georgetown. She obtained a MPH from Boston University, and she did her residency in emergency medicine at BU. She's held multiple leadership positions at Boston Medical Center and BU. She's been the president of the Boston Medical Center. She's the director of the Violence Intervention Advocacy Program. She's vice president of mission and associate chief medical officer of Boston Medical Center. She in 2020 received the American College of Emergency Physicians 2020 Lifetime Achievement Award and the 2019 Massachusetts Public Health Association Award. And Dr. Tracey Dechert is a member of the AAST. She obtained her MD degree from Temple University, did her residency at Medical College of Virginia. She did her fellowship at the University of Pennsylvania in acute care surgery. She's an associate professor of surgery. She is the associate program director of the surgery residency. She's associate chair and faculty development of the diversity program in the department, and she's a recipient, recent recipient of the campus-wide Gold Humanism Faculty of the Year Award. Both Dr. James and Dr. Dechert are founding members of the iSAVE work group from the American College of Surgeons Committee on Trauma, Improving Social Determinants to Attenuate Violence. And they're going to talk to us today about social determinants of health and an equity model and what we can all do to move forward in a positive direction. Dr. Dechert and Dr. James, thank you.
Thank you so much, Ronnie. Can you see my screen okay? Great.
Yes.
So thank you. I am very happy to be here to discuss this important topic and represent the Injury Prevention Committee of AAST. I have nothing to disclose other than I am a fan of Matisse. And the objectives, as you can see here, we do want to discuss social determinants and more specifically in surgical patients. And we also want to touch on surgical equity and social responsibility. And then that's kind of the first half, and then Thea is going to do the second half. So a good definition of health equity is attaining the highest health for all people. But most importantly, it is through the absence of systematic disparities in health between groups with different levels of underlying social advantage or disadvantage. Unfortunately, health equity remains elusive in the US, and that is despite increasing attention, despite increasing research on health inequities, and even though it has been an explicit goal among federal, state, local governments, public health professionals for many years, we still have much work to do. The topic of health and surgical equity falls under a broader recognition that social responsibility and social accountability need increased attention in medicine. A newer discourse on social factors in health has emerged in the US, and this is built on earlier work that was done in Europe and Canada. It is now commonly recognized that healthcare contributes to approximately only 20% of a person's overall health and wellness. So in the last 10 years, the causes and effects of health disparities in the US have really been highlighted across all the medical disciplines. And this graphic emphasizes that the dramatic health problems and disparities that we face cannot be addressed solely and successfully by medical care alone. Why do we need to discuss this as surgeons? When you think of underserved populations, and there are many, the patients who are poor, patients who are under or uninsured, uneducated, patients who are incarcerated or homeless, or racial minorities, underserved populations suffer higher rates of traumatic injury, present with cancers at a later stage, and overall receive worse surgical care. And if you look globally, it's possibly even more grim, but on the globe, there are 5 billion people who lack access to surgical care. And when you look at the poorest third of humanity, they receive only 3.5% of the world's operations. So the term social determinants of health is now used regularly in healthcare. We all kind of know the term. And that wasn't the case until more recently in about the mid or so 1990s. But the association between low socioeconomic status and poor health has been recognized for centuries. Rudolf Virchow of Virchow's triad, he lived and worked in 1800s. It was in Germany, and he's considered the founder of social medicine. He advocated for societal change to address the economic and political conditions that he saw as the root of health inequalities. This here is the World Health Organization's definition of social determinants. And these determinants have an outsized and under-recognized effect on health, which is why we're here today. And are these factors upstream and removed from what happens in our trauma bays, in our operating rooms, in our ICUs? These are not just an extra area to consider. For us to achieve the kind of outcomes that we want for our patients, we need to pay attention to social determinants. What happens to the patients when they get back home? How are they taken care of? We need to consider all of this if we really want to look at long-term outcomes. It's important to also recognize that social determinants impacts everyone. Too often we discuss it as if our patients have social determinants. That's not, of course, the case. We all do. And they are not inherently positive or negative. Addressing our patients' social needs is important, but it is important to recognize the difference of a social need, which is where we address it by having a food bank, for example, in the hospital for patients who struggle to afford food. But wouldn't it be better to have a real and long-term solution? And that would be to address the underlying systemic issues that cause food insecurity in the first place. This graphic provides a nice summary of social determinants, social risk factors, and social needs. Sometimes these terms are often interchanged, incorrectly. So this is a nice way to just see the different sort of social determinants, more the community perspective, and then social risk factors where you're trying to screen your patients, and then the actual social needs of the patients. This is a consistent, coherent, and I would say holistic framework for health professionals in understanding and addressing the social determinants of health. What I like about this graphic is that it reminds us that our education, our work, our advocacy is meant to be and needs to be lifelong. It also emphasizes the role of our organizations and the importance of our communities. It's nice to have a colleague who can draw cartoons. So here is the surgeon operating successfully on the social determinants of health. I'm assuming everyone's laughing right now. So the causes of poor health are disparate and range from geographic location to structural racism to provider cultural awareness. But ultimately, all the social risk factors eventuate in inequitable outcomes for those affected sections of society. And I've highlighted some here that are more specific to surgery. People are talking about this more. So the American College of Surgeons has an initiative, Strong for Surgery. Surgical readiness and recovery are influenced by understanding and managing the 8 topics that you see on the right. But we need to analyze these topics through the lens of social determinants, and then that can reveal future directions for our surgical research to pursue to account for a patient's life circumstances. We need to foster inquiry using community and population-based methods, as we have an opportunity to impact the health of populations and healthcare on a broader scale. We can reframe the questions that we seek to answer and construct our research in a fundamentally different way. So this slide is just to remind us that although we are doing relatively well in this country, but we're still actually surprisingly, look at the slide, right? 20 counties, when you compare the ones with the highest poverty rate and the ones with the lowest, look at the difference in the number of counties that have surgeons. And when you look at the US, 1/3 of US counties have no practicing surgeons. So basically, there are vast surgical deserts throughout, mostly, of course, rural America. And this is approximately 10 million people who then don't have access to us when they need it, which increases, of course, morbidity and mortality. And I'm not trying to say that if you live rural, you're worse off, because if you live in a city, you can be worse off too. There's no sort of safe place to live. And this slide is just highlighting some of the issues that you see, whether you're living in the city or living in a rural location. And then more specifically, trauma, which we all know and love. Despite gradual and continuous growth of our trauma systems here in the United States, as you can see from the slide, there's still quite a bit of this country not covered by trauma systems and trauma surgeons. And the area in the white is about 45 million Americans who do not have access to a level 1 or level 2 center when they are injured. And then more specifically for trauma, we have seen amazing advances, of course, in the care we give, the clinical science, our models, how we care for our patients. And in many ways, trauma is egalitarian, right? We would never stop someone at the trauma bay door and check something to say, are you allowed to come in? But yet, despite that, does that mean we don't have disparities because of the emergent nature of what we do and the fact that it's universal access? So I'm sure you're not surprised that the answer is we are not immune to disparities in trauma. And when you look at the various types of work we do, from injury prevention all the way through, there's examples in each of these areas. Unintentional injury is the leading cause of death between the ages of 1 and 33 in the US, closely followed by homicide and suicide. When you look at access to our care is lacking to a significant proportion of patients, like we just saw on the previous slide. And as we know, if you do not have access to surgical care after trauma, you have higher morbidity and mortality. Then when you look at care and outcomes, does that mean if you get here, then you should be okay? Unfortunately, race, insurance status independently predicts outcome disparities after trauma. Then as you're done the care in our hospitals, you're hopefully going to rehab. But there are studies that show, and more ongoing studies, disadvantaged populations have more limited use of rehabilitation. And then recidivism. These patients are more likely to be minorities, medically uninsured, come from impoverished backgrounds, involved with drug use. I'm going to touch on each of these for just a minute or two. I don't want to get into too much detail about the studies, but just to give you an overall kind of sense. So when you look at injury prevention, residents of lower socioeconomic neighborhoods are at increased risk for exposure to both intentional and unintentional injury. And if you just take one example of drowning, the disparities are actually greatest in swimming pools. Drowning rates among Blacks aged 5 to 19 years, 5.5 higher than those among whites in the same age group. The disparity is greatest at the ages of 11 and 12, where Black children drown in swimming pools at 10 times the rate of whites. And looking at pediatrics, poor housing independently associated, children living in low-income households, 2 times as likely to receive injuries from all causes, 4 times as likely to receive assaults. The elderly, often not thought of as underserved, but yet they're frequently under triage. And we know that injured elderly is skyrocketing relative to our younger populations. So is there an age-related bias? Do we treat the elderly differently? Unfortunately, the elderly in trauma, as we know, is often considered age 55, which is ridiculous, and we should change that, by the way, but that's another discussion. So in this study, there were 3 counties in California, collected data over a 2-year period, 6,000 patients 55 years and older, and looked at mortality. And as you can see in this study, which is several years old now, but probably not that different if it was repeated, 80% of the patients who died, they were not high mechanism of injury, and they were not having major injuries, and yet they died. So suggesting that death is more than the injury, it's a combination of the injury plus their frailty and their health overall. When you look at our care and our outcomes, if you are uninsured, more likely to die after trauma. So there's an insurance disparity. It matters where you live, and the median income of your home address is a predictor. And when you look at race, Black race is an independent predictor of mortality. Insurance has a stronger predictive value than race. And this was just one study. There's many, of course, out there. There's just a couple here of things that we know. So insurance status can be a surrogate for other important factors that affect trauma mortality risk. Then when we think about rehab, I think all of us here know that we struggle trying to get our victims of violence into rehab services. And we know that rehab is essential for improving outcome, especially if you have injuries such as traumatic brain injury or spinal cord. And yet we are not able to give optimal rehab therapy to our patients and therefore optimal recovery. So there are studies that have examined this and found in TBI and spinal cord injury, a difference in patients who were Hispanic. And as you can see here, more likely to be severely disabled, more likely to be unemployed. And then other studies, similar findings, increased mortality with SNF placement even after controlling for injury severity and comorbidities. So decreased use of these various modalities such as rehab is exacerbated, of course, by lack of insurance. And the racial disparities persist regardless of insurance status. But as with many things in social determinants, it's so much more complicated than just your insurance status. Because when you look at a group that has private insurance and compare them to those that are Hispanic and non-Hispanic, both insured, still half as often the Hispanic population is in rehab services. This could be various factors. It could be fear of the medical system, fear of legal repercussions due to immigration status. Worst case, it's our bias or our institutional bias, language barriers, or perhaps they do have quite a bit of family support and choose not to go to rehab. But all of these factors likely play a role. And then when you think of recidivism, as we know, of course, it accounts for many, many high-risk trauma admissions every year. The increase in the healthcare costs, whether you're rural or urban, quite significant. And when you think who is at risk for being a recidivist, what are the risk factors? This is the same factors, right? It's the social determinants: homelessness, alcohol use, drug use, mental illness. And many patients, as we know, have multiple risk factors. So this is a pause for a second to just recognize that if we don't do something about some of this data that we just went over, that we're going to continue to perpetuate these inequities, disparities, inequalities. They'll just continue for generations. So what can we do? And we can do things such as advocacy. So Interestingly, in 1964, J. Engelbert Dunphy gave his electoral address to the American College of Surgeons, and that was titled Responsibility and Authority in American Surgery. And that is where he referred to our profession as a social body with prevention of surgical disease as a core part of its mission. So these ideas aren't all new. Today, general surgeons are more likely than other specialties to consider political involvement as an important public role, but fewer than half reported active involvement in politics or collective advocacy in the past 3 years. And in the past 2 decades, social responsibility has become a more central component of the stated missions of medical education and professional organizations. So there is hope. The most effective solutions to address these social determinants occurs at the policy level. Healthcare organizations are beginning to create and advocate for policy recommendations so that we can educate our legislators on the power that they wield to shape health. And the strongest ethical justification for surgeons' responsibility to society, I think, stems from the social contract. Society invests resources into medical schools for education and research, and there's an understanding that the medical professionals will work towards the common good of the members by improving the health of the public. Because the beneficiaries of this exchange have an equal right to healthcare, it is expected that these benefits would be distributed equitably. One thing we did here at Boston Medical Center, and we are a safety net hospital, the largest in New England. Anywhere from 2/3 to 3/4 of our patients are underserved. 1/3 of our patients, English is not their first language. And something I recently learned is that looking at our patients who present to an ambulatory care center, if they are foreign born, 1 out of 9 have been a survivor of torture. So it made sense as we were thinking about how do you integrate social responsibility into everyday surgical practice that we did a grassroots initiative, and we founded this in 2014, the belief that it is a part of our practice. And the pillars are education, research, advocacy, and service. And this is just some of the work we've done. And this is more of an umbrella organization in a sense that depending on where you are in the country, you would of course have different issues that you see in your communities, but it still falls under this idea that we could be doing advocacy or research in this space. And it is not necessarily our responsibility to completely change a patient's social circumstances, but understanding their social determinants can help us tailor the care to their social circumstances and try to address them as best as possible alongside their hospital admission. And care that takes a patient's social context into account, as well as the needs that their social context creates in their lives, is patient-centered. Research has gotten to a point where disparities related to social determinants are clear. So the next step is to ask why the disparities exist, and then what can we do about it? I'm really setting up Thea for a great next half of the talk, because that's what she's going to be talking about. But so socially responsible surgery has turned the idea of translational research. So instead of translating lab data into a new medication, we think we should identify a health disparity, translate something into advocacy. So as you can see here, volunteerism and commitment to social change declines during clinical training. I'm sure no one's surprised to see that, but it does not have to be the case. We can have a socially accountable curriculum, and we can bring advocacy training into our residencies and medical schools. And as faculty, we can provide mentorship in this space. So we gather data, we show that our hypothesis is true, and then we work to make a solution into law. We can make actionable changes to improve social circumstances. It is hard to do, but it can be done. And with that, I turn it over to Thea.
Thanks, Dr. Dechert.
Here I come. I'm
Thanks, Secretary.
getting it all together here.
Yeah, thank you.
Okay, everybody. So, as Tracey was saying, and as she was talking about so beautifully, talking about social determinants of health, and bringing the most important piece to all of this is awareness, because that is like number one, awareness. And, with awareness comes curiosity. And what most, I would say well-meaning people want to do when they see somebody without something, or, suffering in some way, is they kind of want to help. But it is, and not but, and the best way to know how to help is to understand what's driving it, to understand the root cause. And what I would say is that, as Tracey said, we are the largest safety net hospital in New England, which means, everything she said about our patients, with a majority of them, of our patients being government insured and that type of thing. And, as well-meaning people, the first thing we would want to do is fill these gaps that people have. But what I would say is, as long as we are filling gaps, we will be filling gaps. If we don't understand what caused the gaps, and if we don't aim to eliminate the gaps and give people the opportunity to get out of the line of need, to do things like switch socioeconomic lanes, even, for people to be in a place where they can actually prioritize health, which means they would have to have financial security and economic mobility, and even opportunities to build wealth. Until we address the structural barriers that prevent these things from happening, we can't change it. And so what I want to talk about is to give some tangible examples of how these things happen, and want to use one particular period in time as an example, and also to then give some examples of what we have done in that space. When you say, what can surgeons do? I'll give you some examples of some more examples of what we have done and what we are doing, since we've turned and made a commitment within our own healthcare system to equity. And then I'll finally just give you an example of, I would say, the lowest hanging fruit that we got an opportunity to demonstrate what equity is. Because I would say the greatest challenge to equity is recognizing inequity. And most people don't recognize inequity because it's always been accepted as the status quo. And so it looks normal to people, when in fact it really isn't. This slide right here, which goes along with all the things Tracey just said and showed, is an example of an inequity that is accepted as the status quo, so nobody interrogates it. You can title this with anything, almost anything, and if you measure it by demographics, it will always fall out like this. And the important piece about that to us as physicians is that it absolutely impacts healthcare. For example, people who have lower income have worse health outcomes, and so do their children, because they're just mere beneficiaries of their parents' resources. People with lower education have poorer health outcomes. People who have lower education have lower life expectancies. And for example, this slide right here is a map of where I'm sitting right now, which is Roxbury area. The difference between here and a mile up the street in life expectancy is more than 30 years. And you have to, people will say, oh yeah, of course, because this is Roxbury and that's there, but no one ever imagines that it doesn't necessarily have to be that way, or they don't imagine how it ever happened. They don't imagine that something led to that. And our dean of the School of Public Health here did this sort of mapping study of different T-stops, which is our public transportation system in Boston, the train system. And he looked at, first of all, by T-stop, the percentage of families that live below the poverty line. And these distances are not really far apart. And then he overlaid that with premature death rates at those T-stops, between those T-stops. And then he overlaid that with the percent of residents who are older than 25 with a bachelor's degree by T-stop. And by the way, I've seen a study done in other cities as well. And then he overlaid that with homicide rates by T-Stop, which, let's admit it, is totally, totally predictable. But no one ever understands or thinks about how that happened. And then, the clincher is in those same T-Stop areas, these yellow bars are these, all these, hospitals in Boston, these well-known hospitals in Boston, but they're having no impact on what I just showed you. And one example I like to use as how this may have started was way back in the 1930s, when right after the Great Depression of 1929, the economy was, in a really bad space. And our president at the time, FDR, was trying to resuscitate our country from this economic disaster. And one of the things he did was to create pathways to people building wealth. And as all of you know, one of the most common ways to building wealth in America is through home ownership because of the benefits of home equity. So it was really a brilliant plan. And he even paid housing developers, he would subsidize them to build housing. So it was a great plan, with the exception of, he would pay these housing developers to build this housing, but only if they agreed not to sell the housing to Black people. And they also at that time established something called redlining, which were policies that drew red lines across the country through different communities. And if you lived behind those red lines, you were deemed a financial risk. So you couldn't even access the financial services like getting mortgages and things to even own a house if you wanted to. That also meant that you couldn't build an economy, a lively, economy within the community, with various different types of businesses and things like that, because they too would need mortgages to get these buildings. And, what that translates into at that moment in time, that is impactful year over year, over decade, is it created two distinct socioeconomic populations. And it exists to this day. Now, the impact, that something like that could have is devastating. And I'll make the link between that and now in just a slide or so. This is called trapped right here, because at the exact same time, in the exact same decade, what they did create was public housing. But the problem with public housing is that it's like most subsidies. They are not designed as bridges to a pathway out of them. They actually are traps. For example, if you live in public housing, it's associated with how much income you can earn. And if you earn, people turn down raises, people turn down opportunities to have better jobs. The HR people all around the city in hospitals tell me this all the time. People turn down promotions and things because if they earn more money than allowed, they lose the housing immediately. And so they don't even have an opportunity to have a bridge to get to someplace without, losing the housing. They can only earn $2,000 and they can only have $2,000 in the bank. So you never even get an opportunity to get out of that trap, which, by the way, if they could, would actually contribute to the economy as a whole and the GDP and everything else in a positive way. But because when you have to give people subsidies, you keep giving people subsidies. They don't get to contribute to the economy versus to rely on it, to take care of them. And that is our catchment area. That redlining map is the same. This is our map today. These are our patients. This is where our patients come from. And how that redlining sort of like translates to now is during COVID, for example. At the height of COVID, our hospital was the first one to just tip over. Again, highly expected that this would happen. It was highly predictable. And we kept data, lots of data every single day. And every week we would produce something like this. And what this thing, the highlight of this thing for me is that it's like textbook. It should actually be put in somebody's historical textbook, history book, when it talks about public health, for example, because based upon what I opened up these slides with, the majority of the patients in our hospital who had COVID, they had their highest level of education was high school. A majority of these patients came from those red line communities. A majority of these patients, when they had comorbidities, these are not like the usual people with comorbidities who are 70 years old, 60 years old. Our patients have serious comorbidities heart disease and kidney disease, hypertension, diabetes out of control, they're in their 40s when they have this type of disease state. So those things that happened a long, long time ago, this is why nothing ever changes. That's one reason, because when you create something like that, and then you embed some traps in it to prevent it from changing, it becomes a self-fulfilling prophecy. And what happens when we think about people who come from a different, a certain location or a certain socioeconomic status, is sort of like when we get an opportunity to help, to intervene, we usually, accept this notion that, well, you come from here, you are that, so you get this, because that's the way it's always been. So we set low bars and they become self-fulfilling prophecies. Also, it means that, we did this, the Boston Globe did this study back in 2017, just to look at median net wealth gap in a 7-part race series, which showed that, in our city, the median net wealth gap is $247,000 for whites and $8 for blacks, which essentially means that if you got COVID and you were in that $8 bracket, you didn't have 6 months or a year's worth of income that would enable you to stay home if your job's shut down, or if you got furloughed or something. You are likely to just like fall off, and if you had a job, it would likely be a job where you were facing the public and might not be as safe. All kinds of things that make the difference between when you have financial stability and economic mobility and when you do not. And so back in 2018, in Massachusetts, Mass Health, which is like Medicaid, decided it was going to change the reimbursement model for our state. And it said, we're no longer going to do a fee-for-service model where you get paid. If a patient comes in 25 times in a year, fine, you get paid for it. They said, no, we won't do this. We're going to change it to a value-based system where we want you to decrease costs, improve outcomes, and we want you to achieve it by focusing on determinants of health. And we will give you financial support to create an infrastructure to be able to do that. Well, this thing gave us an opportunity to ask ourselves, what is the role of a safety net hospital? Is it charity exclusively into perpetuity, which doesn't change anything, or is it in fact equity? And I'm proud to say we chose equity. But we have taken a serious deep dive into this equity thing, and we have taken it really, 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 really seriously. We've engaged it across the entire healthcare system in all areas, in the clinical areas, in education, in research. We've created a community engagement policy, not even a policy, but a program. We've decided that we won't just engage with the community when you need a representative from the community to sit on some committee to satisfy some governors or something, which isn't the best way to engage that person or leverage what they can help us with. We decided that we would have it the opposite, and that in terms of numbers, and we would have ongoing, deep, robust relationships with communities. And I'll show you how we did that in just a few slides. So the first thing we decided to do was look at ourselves. We looked internally and we looked at all the data inside the hospital. We looked at our policies. We wanted to see where we might be complicit in things that don't represent equity. We even did things like look at outcomes, and no surprise, of course we found things because we were looking for it, and that's exactly what we wanted to do. We looked at how these things kind of happen in this sort of like circular fashion, like a person who has high disease prevalence comes in the hospital, they have a really poor engagement in the hospital. Perfect example is maybe someone with sickle cell. Everybody knows the kind of tension that happens with sickle cell patients because they require high levels of narcotics. Sometimes, there can be disagreements between the patient and the provider. And whenever somebody feels threatened because, patient is engaging with this thing with them, they, call public safety. Public safety always triggers a flag in your chart. And so then henceforth, every time that person rolls in the hospital, there's that flag. It sort of like stigmatizes that person. These are things that represent inequity, because even if you're not here for something clinical, you might be here to pick up a prescription or whatever, you might look around and there's public safety. And so, but the long and the short of it is, there's an a negative experience that first time. And so the person has less trust in the system. And when the vaccine rolled out and people were talking about the COVID vaccine and people of color being more hesitant to take it because they don't trust the system, that's the kind of thing they're talking about. Not so much Tuskegee, but something that happened 2 hours ago, 2 days ago. And so you can see how the cycle goes, because then when they don't have trust in the system, they don't come back when they should. They don't come back until they're worse. And then the cycle kind of just like keeps going like that. But these are things we have not like necessarily be, thinking about when they're happening. Like we've always had a ton of programs. I mean, a ton of programs. But what I would say is what we have primarily done is we filled a lot of gaps that people have, not necessarily eliminating the gaps, meaning that you make it so the person doesn't need whatever that subsidy is or whatever that program is offering. And I'll give you an example of how we're transforming that. So this program called Street Cred at the top, what it does is the pediatricians do people's taxes in the pediatrics clinic so that they can get access to earned income tax credit. It's only about 5 years old. They've gotten back about $8 million or so for people, but we're now adding it on to, we're working with an organization called Compass Working Capital, which works against that thing that happened in the 1930s in terms of public housing. Compass leverages a HUD program that says, called Family Self-Sufficiency Program, that says you can earn more money, and you can get promotions without losing your public housing. That money goes into escrow for home ownership and even for education, because everyone in your household is eligible for it. So we're adding that on to the Street Cred program. We're about to do a pilot on that. The other thing we do is we screen our patients for determinants of health in all the ambulatory care clinics, and it's actually rolled out now to the specialty clinics, including surgery, dermatology. We're about to start it in the ED. And that's basically so that doctors know, because it's in Epic, it's right there. You can see what gaps your patient might have when you're getting ready to create a treatment plan. You can understand what challenges to that plan actually working might be. It's right in front of you. The patient might be homeless, so don't prescribe them insulin. They have no place to store it. Or, the person has a housing issue. But it also asks people about things like education and things like employment. Do you want help with that? And I actually had to advocate pretty hard to get those two questions in that screener some years ago. And believe me, we get the data every single month. And those, education and employment rank right up there with things like food insecurity that people want help with. And then we connect them to those resources, because it's not lost on them, how to get ahead. We also belong to the Healthcare Anchor Network, which is about 61 hospitals around the country that focus on building more inclusive, sustainable local economies through hospitals being intentional about how they make everyday decisions in hiring, investment, and procurement. And some examples of how we've enacted that is something like this, where in Massachusetts, when you build onto your hospital, you have to give 5% of the total cost of it to the community. We did a campus redesign 3 years ago, or 4 years ago, and we asked the state if we could give our money or commit our money to multiple different housing initiatives. They approved it. We were able to invest in a private equity fund and think about how this is different from the 1930s. This particular private equity fund will only fund housing developers if whatever they build provides access to employment, affordable housing, green walking space, transit, and healthy, affordable food. And that translated into us to this housing development here with 323 new units, some to rent, but also some to own. So there's opportunities to build wealth. 60% of the tradespeople on that construction site come from the community. It is near transit. The people wanted a grocery store there. And this is the most recent thing that's happened. So, we gave a grocery store that aligned with our values, a no interest loan to build a store out on the first floor of this place here. And, then COVID happened and we just picked up everything again, I would say starting in January. And here's the thing, when we invested in that grocery store, and no, it sounds cliche, but it seemed like a really great thing at that time. But now we've sort of like changed our thinking on it because, yeah, they're owners of, there's a company that owns this store, these guys. And then they got some operators from the community to operate the store. But now we've been thinking about it from an equity perspective. We want the operators to become the owners. And we want the store employees to actually have equity in the store, and so that's the conversations that we're having with them right now, just to show you how you can do whatever you want to do. People say you can't boil the ocean, but you can do kind of like whatever you want to do. You either choose the status quo or you choose equity. You just have to be intentional about whatever it is you want to do. And I was just over there recently. That's the store on the bottom level. There's a Montessori school there right next to it. And right next to that is this 24-hour gym. Also, when we got that permission from the state, it set it up for other hospitals in the city, who have far more money than us. Like we had 6.5 million, Children's had 53.4. We had a meeting today with Mass General Brigham. They've now got a $62 million DON. But what it did was it enabled them to find a way to do something very similar. So they invested with us in this stable housing initiative. This is just a snapshot of what we did in procurement. Again, just showing you what you can do with intentionality. When we started out in October of 2018, we were investing $2 million in procuring from minorities, women, people with disabilities, veterans, and with intentionality in just a year, we went up to 23 million. We got this $5 million grant from JP Morgan Chase. I don't want to take up too much time, but we were able to get this based upon what we did with the hospitals. That put us in a position for the three of us and the city of Boston and some other people to apply for this $5 million grant. It is about housing preservation, housing acquisition, and it's about economic mobility through intentional jobs. But it's not the usual way you get jobs. One of the people we're working with, what they do is get employees to open up every job they have in a place, not just them choosing who goes where, and then we feed the pipeline into these jobs. As Tracey was saying to you, we were the first hospital to tilt when this happened, but she was telling you a story about, the ICU and everything. This picture reminded me of it. But now everybody across the country has talked about commitment to equity. Everybody said that, and everybody knows who suffered the most. But when the vaccines came online, that's really not necessarily where they were deployed, to those neighborhoods. That's what I mean about, the status quo, making it so that inequity is unrecognizable. And in our city was no different. And when that happened, we decided, well, you know what? We will create access to the vaccines in our own city. We created 7 sites within the city. Actually, the state actually helped us. They gave us the supply. But the way we did this, and I'll link this back to the community engagement piece I was telling you about, we asked the people in communities, we convened different people by Zoom, different groups, faith leaders, women's groups, men's groups, social groups, all kinds of people. We presented education about the vaccine, but it was mainly to ask them, how could we do this? What would it look like to set up sites in the community? What should they look like? What should they feel like? How should they be operationalized? And they helped us to do this. And can show you, we had this challenge in front of us, which shows how, hesitant people of color, were about the vaccine. So it's really important for us to get this thing right. So we got together a steering committee. We did a huge media campaign. I'm actually just going to keep going quickly now just to get through this. But these are all the various different ways in which we reached, the community. We have something that you should take a look at. You can Google it. It's called Health City. If you do Health City Boston Medical Center, you'll see all these things we have online about this and many other different things. We actually, with intentionality, went out to get these people and close these gaps. And then if you look at this, you see what else can happen with intentionality. If you look at the state on the left and you look at us on the right, Boston Medical Center, and you can see that when you have an intentionality to do something, like we did for that population, you can see the difference in, you know, how much easier it is, or how many more people, or how you are more likely to be able to engage people, you know, to get the vaccine. And this is the last slide. We started March 1st. On that day, we had done like 13,000 cumulative doses. This was on 5/11, but right now we're up to about 140,000. And because we have a 40-page daily dashboard. I see this thing every single day. So I won't go into this because I want to keep going. But I will show this at the end because I am, you know, I'm optimistic by nature. And so I always end things with this slide because I really believe, and it's not unjustified. I really do believe that we can do anything we want to do. And so can you. So thank you. I'll stop sharing.
Thank you, Dr. James. Thank you, Dr. Dechert. Outstanding talks, and thank you both, and thanks to the Prevention Committee for sponsoring and for encouraging the talk. In the chat, we've got a question for Dr. Hussein. It says that they've heard some sentiment within and outside the medical community that we need to shift the focus from simply recognizing and documenting disparities to acting on them. We know many of these root causes, as you both discussed, lie outside of direct medical care. Do you think advocacy for large-scale policy changes are the most important tool for change, or do we need to focus on factors within our institution and our control? Do you think the focus of our efforts should evolve over the course of one's career as a physician or surgeon? Very thoughtful question. What do y'all think?
I think it's all of them. I don't think you choose a lane. It's all at once. And we've got people here who all of them have a lane. And we do exactly that, you know, including policy. I mean, just 2 weeks ago, I was talking to the House Rules Committee on the same exact stuff. So, yeah, I think it's all of it. Tracey, what do you think?
Yeah, absolutely. I think because either alone, right, isn't enough. And this is such a big issue that we do have to confront it from kind of every angle that we have. And I think one thing we could do to help in regards to sort of your question is teach advocacy training to our medical students and then to our residents. And then as we are making our physicians and surgeons, they actually would maybe know how to do some of this. And whether they do it in their career or not later, some of them will. And we probably should be doing more kind of in the health policy teaching. So that way we can do more of that work in addition to the stuff we're doing locally.
By the way, we have a young surgeon here who is all over that. I'm talking about Mike Polson, Tracey, who wrote this unbelievable op-ed in the Globe a couple of weeks ago. I mean, woo, unbelievable, powerful, really powerful.
So another question from Dr. Joseph. Wonderful presentation, Dr. Dechert and Dr. James. You work at a place where there's at least some culture recognizing the importance of social determinants of health. What about advice for surgeons who work at places where that culture doesn't really exist, and really how to get started, how to get things rolling?
I think one idea, I'm not sure if this would work, but in general, it seems to me that the medical students and the residents are usually in a different place than often sort of the leadership and the faculty. They have learned different things in their education than we did. Like, I don't remember learning social determinants, but now they all learn it. And when I started my group here, it was me and a handful of medical students, and their passion is, of course, amazing. And they honestly, they have more time than we do. So you want to somewhat take advantage of the fact that they have passion and time. And it took a while. I mean, I think honestly, people didn't take it seriously for a while because it was just this grassroots work. But now, a couple of years later, when we start doing more and doing research and trying to, you know, it is taken seriously. So I think that's one option, is to reach out to the students and residents and see if you can get them to help you. And if they just need one faculty member.
Dr. James?
Yeah, I would say the exact same thing. But I would say the first thing you do is, have an intentionality to actually do something, and that way you won't second guess yourself. You might second guess yourself, but if your intention is to get it done, you'll actually do it. And again, like Tracey said, finding allies, and she's right. The medical students are, they're ripe, for change. And in many ways, they're already questioning everything. I will be really honest with you. I actually don't think the medical education system is that relevant these days, because it just focuses on disease. And, when it hardly relates a human to it. But when it does, it's an ideal human with an ideal life, never challenged by anything. And so, but that's not what you see in reality. So, I think for us to be better physicians and have better outcomes and things like that, the whole thing needs to be redone.
Thank you. Another question. Thanks to you both for an outstanding presentation. What's the best way for trauma surgeons to eliminate the racial wealth gap on a national level?
You should Google, because we're doing some things on one level at a time. One of the equity pillars we have is economic mobility. You should Google McKinsey and Company. McKinsey, the organization McKinsey, and Google. It now has an Institute for Black Wealth or something like that. If you put in McKinsey and you put an Institute for Black Economic Mobility or something like that, it'll come up. There is a nice library of things, of papers they've written since 2019, and you'll get everything and more if you just take a look at that.
Thank you.
We've actually invited them here. We've hosted a webinar for them, actually.
So, Dr. James, a question for you. You talk about moving from charity to equity. I think part of your talk, but could you just explain a little bit more for those of us or people who may not fully understand, exactly what you're talking about? I've been on many small group meetings with you, and you have sort of a gift of being able to explain things in a way that make it easier for people who maybe haven't thought of that. What is it? I think most people think when you're providing charity care, you're doing the Lord's work. Can you help people understand, how the move from charity to equity and caring for our children, and just if you just talk just a little bit about it.
Sure. So, I think I can use something that's really relevant. Back in 2006, when the mayor of Boston came to us and asked us to do something about the resurgence of interpersonal violence in our city, I didn't know where to start, but I volunteered to champion it, and I started looking at research. There were only 3 hospital-based violence intervention programs in the country at the time. And one of them had started to publish on measures of success. And the things that were being measured were, and it's a beloved colleague of mine, by the way, I'm going to say that. But the things were being measured were like re-injury, reincarceration, dropped out of school, these type things. And I was trying to figure out, I didn't understand how you measure success if you just stop there. So what it did for me was to make me think, what's the difference between myself, a Black female, and these other Black males and females who were coming in here with all these gunshot wounds? And the only thing I could see was that they just had not had someone who nudged them, pulled them along, and shoved them in a different direction to give them different opportunities. Because otherwise, there was no privilege. I had none of that growing up. And so just people making different decisions and being in the right place, right time, or whatever. But so I said, well, that's what we'll do. We'll do that. Because I guess in other words, I was like, we won't set low bars. We'll set really high bars. And so when we engage with them, there were mental health workers who work in tandem with us. And we asked them, how this happened, and trying to get them to think about, if you had your choice, what would you be doing? What would you like to be? What would be your life goal if you had a choice? And whatever they said, that's kind of like what we went after. And then we met other, people around the country, like Dr. Rochelle Dechert and, Dr. Cools too. But in 2007, 2008, we got together, 7 of us, and created this, what was then called the National Network of Hospital-Based Violence Intervention Programs, which is now called the HAVI, the Health Alliance for Violence Intervention. And so we all have those kind of goals that we set for people. And I guess what I'm saying is, you're actually not just filling the gap they might have from food insecurity, because a lot of these kids came in, had that as well, but getting to the root cause of how they may have gotten that way. I guess the difference is, I just didn't see any reason why they couldn't be me. And when I say me, I mean waking up every day, being able to choose your path forward in life. Because if you just fill gaps, if you send somebody to a food pantry, it should not be like your Piggly Wiggly for life, your Stop and Shop, your whatever for life. That is something that you may need in a moment, like some people who have had to get in food lines who were doing quite well before that, but that will not be for the rest of your life. And so I guess you just have to think of people as being able to do anything you can do with the right, the right opportunities and the obstacles moved out of the way. I'm an ER doctor. I just see the same patterns over and over and over again. And you get to some point where you ask yourself, what value are you bringing? I mean, what am I doing? I'm changing nothing if I don't attempt to change anything. So I don't know if that explains it, Dr. Stewart, but, just, the other thing is to think about, is that what you would want for yourself? Would you just want to be going to a food pantry for the rest of your life? And by the way, some patients can't imagine not doing that, because we did a study on that in the food pantry, asking people, what would it take for you not to need this again? Some people said they couldn't imagine not needing it again. So just disrupting, the status quo, just disrupting it, just doing something different. Just do something different.
I think one time in a meeting, you said something like this, that when we, it's very simple, when we commit that we'll care for each other's children the way we care for our own with the same approach, then we can move from charity to equity.
That's right. That's exactly right. That's exactly right. That's right. Someone asked me once, how do you deal with patients like these patients that come in with gunshot wounds? I told them, I start off by, I understand that they're human. That's number one. They're human, and we all need the same thing, basically, basic human things. We need safety. We need food. We need somebody that cares about us, something to care for. We need opportunities. We need the ability to thrive, not merely just to survive.
Thank you so much. I think, unfortunately, we're out of time, but this has been an amazing lectures, amazing talk. We're really, really grateful for you taking the time to present here, and for your leadership, and for really leading the way. We're really, really grateful, and thank you very much. Thanks for all the attendees. We're also grateful that you're here, and this is Trauma Awareness Month. So for those of you on social media, please tweet these principles, talk about these things, and then I think the core message is, there's all things that we can do in our own individual health systems and our own practices where we can make a difference in this way. And so go back to your daily work and think about moving from charity to equity, and making these changes. So thank you both very much. Thanks to the AAST for hosting us and sponsoring it. Thanks, Sophia, for keeping us all straight and on time. And we're grateful. So thank you, and goodbye. Thank you all.
Bye-bye.